I'm a Mennonite. I was born in a faith tradition, a Christian faith tradition, based on community service to others and pacifism. I was raised in a small town in Kansas. It was mostly Mennonites. It was kind of a weird small town in Kansas. It was rural, but it was a wealthy engineering kind of area. And the church communities took in a lot of refugees from Nigeria, from Vietnam, from Cambodia. My mom taught most of them English. One morning, I was sitting around the table with my brother and a recent crop of Laotian children. There were 3 of them in this family. And later that morning, we went on a walk, working on our nouns, our outdoor nouns. There was, there was the trees, there was the rocks, there was the birds. The rock and the bird caught the attention of the oldest brother, who picked up a golf ball-sized rock and in the blink of an eye spun around and killed a robin from 20 feet away. He spun around and watched my brother and my jaw drop at his amazing athleticism and shared one of his few words in English. Lunch. It was at that point, at a pretty young age, I realized I have a wicked privileged life. And all of a sudden, my world view was a little bit blown up, of sitting around feeling like how we're all this interwoven community and how we're all so very much alike, but then immediately how I will never understand the pangs of hunger or starvation or what it's like to be driven from your country as a refugee. That set my compass on social justice. I knew that my profession, I had to do something that had a direct impact on the wellness of others. Wellness of others, particularly others that were less privileged. So medicine seemed like a good idea. So I went to college, and you have to pick a degree, so I said pre-med, that seemed nice. And I followed that path, and it worked out for me. I liked medicine. I was good at science, and so I went to med school after bombing the MCAT once. I hate tests. And I got into Morehouse School of Medicine, where I was one of 3 white people in a class of African Americans, mostly in Southwest Atlanta, and continued to have my mind blown by culture and learning what it's like to be different than others, and also learning this really bizarre pseudo-intimacy that is doctoring, that you walk into your life. And I remember distinctly the first time it happened. They don't get that the short white coat means that I don't know Jack yet. I walk into the room and they just lay their life out in front of me and scared the shit out of me. Why are they telling me this? What am I supposed to do with this information? But they were sharing it with me for hopes that I could do something with it. And I learned to do things with it, slowly. And I love that dirty, personal, human interaction that is primary care, and that drove me to it. And I also got really pissed off at the really dysfunctional system that really doesn't let me do it very well. Perhaps I got my love of efficiency from my father. He was a mathematician turned computer programmer. I hate waste. I'm not a fan of dilly-dally, and I think the hate of waste is partially for waste itself, but also a hate because I think we all have to be good stewards of the resources that we're given. And when we have a system that's laying waste to people that desperately need their services, and we're killing people unnecessarily with poorly functioning healthcare systems, I wasn't a fan of it. So, after my residency, I learned that I couldn't just see patients 24/7, all day, every day. And so I got my faculty development fellowship and got my master's in public health with a focus on healthcare policy, law, and ethics. And as I started looking around for jobs after my fellowship, besides going anywhere where my wife was willing to move, I was looking for the best fit. What was the fit for me? And I had read a lot about Massachusetts and Virginia during my healthcare policy, law, and ethics classes, about a state that was bold enough to go for universal coverage. What would that actually look like? Because I had enough of having to see patients in my free clinic, which was great and feeling great that I could provide that service. But you know what? You need a stress test. You need a heart cath. You need something that is not in this free clinic. And now, what can I do for you? I can't do anything for you. And that drove me nuts, and it didn't feel like my job, but yet there I was with that task in front of me to try to figure out how do I get this patient what I want. So I moved to Massachusetts. And my mission now is to train transformational leaders to drive the primary care revolution that will save the U.S. healthcare system. Don't worry, I'm going to tell you how we're going to do it. So, a little bit of context. Most of you are probably aware of this. We spend way too much money. We are at about $8,400 per person, for every person in the United States right now. That means that we're spending just under 18% of our GDP, which is about twice as much as any other industrialized nation. Healthcare costs have outpaced any other expenditures. We spend both more per capita and also out of pocket. More and more Americans are uninsured. It's worse if you're black or if you're poor, or if you're a minority, like most other things. You have about a 5-year life expectancy decrease, and you're about twice as likely to get a late diagnosis of cancer. About 3 times more likely for a late diagnosis of breast cancer. And we're just barely above Cuba in our health law. Cuba's pretty good, too. Our all-cause mortality is higher. Our ability to decrease neonatal mortality is worse. And we're just not very good all around. So we need a superhero. A cute, gratuitous picture of Sun doing really cute 4-year-old things. But we need this kind of boldness to go on. So, where are we at? Now, as much as I would love the idea that like behind some big wooden door, there's this fat monocle wearing, pinstripe wearing Monopoly guy that we can just break down the door and punch him in the face and this will all get better. I've learned through my systems thinking that that's really not the case. Dr. Paul Talden said, systems are perfectly designed to give you the results that they get. Right? There's no mistake about where we're at. It's what we've built and where we're at. So don't get mad, get data. Figure out where we're going wrong and how do we start fixing that. So how have we gotten to where we're at? We have a health system built on a traditionally fee-for-service model that rewards piecemeal work and volume of services rather than prevention of illness and coordination of care. So the more procedures I do, the more people I see, the more people and things that I can get through, the more I get paid. Not because I'm evil and money is the only thing that drives me, but if you have a system that does that exponentially, you're going to create a system that gets really good at doing that. We need more primary care doctors. I think Tim put forth a good argument on some of the reasons that we need more primary care doctors, and I'm going to tell you why I think why we're not getting more primary care doctors. The estimates, as Tim alluded to, are variable, but a lot is certainly the answer about how many that we need. The Accountable Care Act promises, depending on how many states adopt and what human behavior is, to ensure about 30 million more Americans. We know from health economists and behavioralists that once you're insured, people would actually like to use their insurance and would actually like to see their doctor. And so the behaviors start to change and they actually like to go see their doctors. In family medicine, we graduate about 2,400 family medicine doctors a year. More than 50% of those spots are currently filled by foreign grads. Why are they filled by foreign grads? I was told I'm too smart to be a primary care doctor. Every one of my residents was told they are too smart to be a family medicine doctor. Why are they told that? Where are our med schools? I wholeheartedly agree with Tim that our medical schools need to drastically change the students that we're admitting and really drastically look at the curriculums that we're doing. Right now, we're a test-driven organization that you have to pass the MCAT, which I didn't the first time. And then you have to pass your USMLE, step 1, 2, and 3, and then you have to pass your boards. We're teaching to these tests because if you don't, then your scores go down, university, you're less likely to get on those top lists of the U.S. News and World Report. And every one of our medical schools, by definition, are housed in tertiary medical centers. The ecology of healthcare, the number of people that are actually seen in our population at these academic health centers, is about 0.1% of the healthcare that's delivered. So we, as med students, come in actually quite altruistic, and then our system systematically beats it out of people. There's actually pretty good data to show that we do that. How do we do that differently? One way that we can do that differently is to start to train differently. One way that we're training differently at Cambridge Health Alliance is we have the Harvard Academic, the collaborative, I'm clearly not involved with the program. It's a longitudinal clerkship for the third-year medical students. There's a number of medical schools across the U.S. that are experimenting with this, and they've done studies that have shown that they do not beat the humanity out of people as consistently. And how this is designed, instead of you having your typical third-year medical student experience where you go do a month of surgery and a month of psychiatry and a month of pediatrics, you get a panel of patients. You become a primary care physician, sort of. You're linked to a primary care physician, and you start to follow your patients through their experiences of care. You actually start to know your patients. And you know what? We've learned a hell of a lot from these students because they see the health system in an entirely different light than any of us doing the work. Because I make too much money to anybody let me walk around and chase people around to see what happens to all my patients when they go and do things. This is what we make the students do, and they learn all sorts of fantastic things about how our health system needs to improve. Med students are also not dumb. So when they're in this tertiary care medical center and they're looking at their now average debt of about $250,000 to get through medical school, and they're saying maybe even they love primary care. Maybe they are in a school that has a robust primary care department. But they see that, I also love cardiology, and there's about a $3.5 million pay differential over the course of my career. Maybe I don't love primary care all that much. Why do cardiologists and orthopedic surgeons and dermatologists make so much more money than primary care doctors? Every system is perfectly designed to give you the results that it yields. The American Medical Association, the largest physician organization in the United States, exercises their First Amendment rights to lobby Congress and to lobby the Center for Medicaid and Medicare Services. Medicare is the 100-pound gorilla of insurers. They are the largest insurer in the United States. Pretty much every other insurance company looks to Medicare to see how they should base their prices. And so when a hospital goes to negotiate a contract, we'll give you 1.2% of Medicare, we'll give you 0.8% of Medicare. And so this is the organization, the Resource Utilization Committee of the American Medical Association, who has made up their members by selecting one member from each of the national societies, plus a couple new members. I like this one down here. Before there was, well, I'll just let you look at the list. What do you notice about the list of societies over there? How many core primary care societies do you see over there?
What is that at the bottom?
Yeah, there's a primary care rotating seat. That's new as of a year or two ago because they were catching a lot of heat. The American Academy of Family Physicians, and at a meeting I was at a few years ago, there was a motion on the floor actually to pull our member from the Resource Utilization Committee because the RUC was doing something that rhymes with RUC to us for a long time. So we see the American College of Surgeons, the American College of Plastic Surgeons, the American College of Anesthesiologists, the American College of Pediatric Surgical Societies, thoracic surgeons, you get my point. This is why specialists are paid more in the United States than anywhere else. In Denmark, they use a different language. Here we talk about specialists and generalists. In Denmark, the translation is more closely to comprehensibilists and partialists. We don't value care of the whole individual and weaving it together. And that is one of the huge downfalls of our system right now. And I think I completely agree with Tim that a lot of what is going to happen is we're going to see a lot more people doing a lot more of this care that aren't just physicians. I am okay with that, and we absolutely need that to happen. That being said, we have to figure out how to weave that together so the relationships can be maintained. So, what do we want from a health system? The IHI, some of my neighbors down the street, Institute for Healthcare Improvement, Don Berwick wrote a paper in 2008 describing the triple aim, saying what we really need from a health system is we need to improve the population as well as the individual health. We need to enhance the experience of care that includes quality, access, reliability, and we have to reduce the per capita cost. There's also been a lot of talk about the fourth aim, which is joy in the workplace. Now that might sound a little like hippy-dippy family medicine, okay, that's what's going on. But Tim's exactly right. Looking at the satisfaction, job satisfaction of the workforce right now, if we keep burning people out at the pace that we are now, this is not a sustainable product. We have to figure out how to create systems that are going to make this work tenable. So, how do we do this? Here comes the solution part. So, back in about 2000, the American Academy of Family Physicians and some other primary care organizations got together and commissioned the Future of Family Medicine report. They've been seeing the quality data come out, they've been seeing the costs go up, and they said, what do we need to do to lead the changes that we need to see? So they started talking about new models of care. They started talking about team-based care. They started talking about patient engagement and how we really get people to interact with us, and how do we get rid of this word non-compliant, which is probably not a very helpful word when we tell people what to do and they don't do it. How do we start to do this work very differently? So, we're scientists, so we decided to study it, right? So that was the launch of TransferMed. TransferMed was a national demonstration project which took 38 sites from across the U.S. that said, yes, we want to become patient-centered medical homes. We'll talk some more about that language in a minute. We're looking at these new models of care. We want to engage. We want to try that. Nobody got any money because they wanted this to be an in vivo experiment. With 18 of the sites, they gave them consultants to work with them in their transformation. The 18 other sites were control groups. They studied them for 5 years, and their big conclusion was, oh, crap, this is hard. There were a couple things they realized. One was that there were really very few consistencies besides people really had trouble changing the culture of medicine, which is a very thick, heavy, slow culture to move. But one of the things was relationships seemed to be key, both within the teams and with the interactions with their patients. And also that we need really robust information technology systems if we're going to do this well. If we're going to be proactive about care, if we're going to start to try to figure out who are my diabetics that haven't been seen, who are my children that need vaccinations, if we're trying to leaf through 10,000 paper charts to figure that out, we just cannot do that work. We need that technology to do that. So then was the launch of the P4 program, which we've been a part of, which was saying, okay, if we're saying this next generation of primary care doctor needs all these new skills, maybe we should look at how we're training them. That's where we come in. So, what were our 4 pillars? Firstly, we said, you know what? We are outpatient specialists. Why do we spend so much time in the hospital? So we developed a longitudinal curriculum where we have the majority of our time spent in the outpatient clinic. Our residents, by the time they graduate, have seen 2,200 patients. They carry their own panel of about 350 patients, and they are their primary care doctors. If you compare that to the way most internal medicine programs run, and most internal medicine, even primary care ones, because of partly their ACGME requirements to stay accredited, most of them don't go into primary care. Most of them go into subspecialties for lots of different reasons. And they have about 1 session of clinic a week in their continuity clinic. I would not want to learn to go practice full-time primary care after having done 1 session a week of primary care. Train to do what you're going to do. So we want our doctors in the family medicine center, learning from family medicine doctors, doing that work more. We need experts in information mastery. I love information mastery. This is all about how do you know what you know and figure out what you need to figure out and have confidence that you know the answer. Data couplers, guidelines. But who wrote those guidelines? If American starts at the start of the guideline, probably not the best guideline, unfortunately. The American Academy of X, it's evidence-based. They're all evidence-based, but how exactly was that evidence used? Sometimes we talk about bog sats, a bunch of old guys sitting around talking. That's how some of these get written. And I'm very critical about these, obviously, by my language. So, trust the guidelines from Europe, England, they do much better. Have a competency-based education. We have the radical notion that we actually tell the residents what we want them to know instead of a time-based education where if you go to a month of these things, then we hope that you're actually competent when you come out. Because part of what we need to do is make them lifelong independent adult learners. They're all adults and they're all learners, but we've never treated them that way. We've given them large bodies of knowledge and tests. We've put their butts in chairs like this and we've talked to them and made them read ridiculous books and haven't taught them how to think for themselves, ask their own questions, and figure out how to figure out what they need to figure out, when they need to figure out it, right in front of their patient, right with them, with that monitor, looking up the answer. We give them opportunities to chase their areas of concentration, to pick essentially a minor. What are they interested in? Sports medicine, reproductive health, community health. What's that thing that makes them go, yeah, this is what I love? Because if I just try to jam them into the mold of what I think a great primary care doctor is going to be, they're never going to reach their full potential. They're going to reach their full potential if they reach their goals. And so how do we give them the opportunity to chase what's most important to them and what they love the most? And then an executive skills curriculum where we try to really focus on how do we teach them what they need to know to be transformational leaders. Don Berwick, I mentioned already once before. I admit I have a little man crush on Don Berwick. I heard him speak when he was freshly off his seat after being chief of the Center for Medicaid and Medicare Services. And he said, affecting change at the in the U.S. healthcare system from the federal level is like trying to sew a quilt wearing 3 pairs of mittens. It's very crude. Now, we desperately need health reform. We desperately need change. We need these things to help us make insurance companies behave, try to figure out how to level the playing field, how to change payment reform. Those things desperately need to happen. But those changes cannot do the fine surgical work of helping me find and eliminate the little bits of waste that are scattered throughout my health system. And if we come at it with a hatchet, we're going to cut off a lot of good stuff along with the bad. So how do we teach not just me, but my front desk person, my medical assistant, my nurse, using things like lean technology, which was Toyota manufacturing, of how do you get everybody to start to see and systematically eliminate waste in all of their everyday work. So we need a model for improvement. Systems improvement is a big thing that we talk about. This is not cognitively difficult, which confuses residents because they went to med school. They like cognitively difficult things. It's 3 questions. What are you trying to accomplish? How will you know that a change is an improvement, i.e., what are you going to measure? And what changes can we make that will result in improvement? Go try it right now, this afternoon, with your medical assistant while you're seeing patients. Did it work? No? What happened? Think about it. Plan some more. Do it tomorrow. Did it work? A little bit better. Next day, tell one of your other residents. Can they do it? How are you rooming patients? Hey, there's these little plastic tabs outside of our room that look like flags. I bet that might help us figure out where each other is. Maybe we should use these. How do you start doing these things to start doing active improvement in your everyday work and your everyday lives? Current projects that are going on right now, MyChart sign up. How do we get more patients on our online portal? Urine flow, right? That's a good one. What I mean by that is any woman coming in, no offense to the gents, but urinary tract infections are much more common in women. Any woman that's coming in with abdominal pain needs a UA. And if you're of reproductive age, I also need a urine pregnancy test. Do I need to go and sit with you to have that conversation, to learn that you have burning when you pee and abdominal pain and you're a woman of reproductive age, and then order the urinary test, get you to go to the bathroom, get my lab to run it, and wait for you to do that until we can start talking to you? God, I hope not. That's really inefficient. The MA knows that. They know why they're here. Can that all happen? Orders protocolized so that happens. So when I walk in the room, hey, you have a UTI. Here's some antibiotics. Get out of here. Or is there something else that really brought you here? Continuity by teamlet. We're working on that with a group from Northeastern here. James Bennion and the health science engineering crew to try to figure out how do we schedule smarter. Residency clinics, by definition, are full of part-time clinicians. I see patients 2 half days a week. My residents, depending on their rotation, aren't there all the time. So how do we divide up groups so instead of you seeing one of 40 different doctors, if I'm not there, you see one of 4 different doctors? How do we schedule smarter so we can try to create that continuity so people can see that? The improvement tree is trying to talk to our patients about what we're trying to improve and trying to hear, is it working? Did it make your experience better? Is it working better? Call routine. Calls in, calls out, calls in, calls out. We get over 500 phone calls a day. We learned that if we spend just a little bit more time on that phone call, about 30% of the calls that we get are callbacks. It's not the first time that they called. Can we get much more efficient about collecting the data that we actually need to answer that call, ideally on the first touch? That would be lovely. We're changing concepts now. What is the #1 health risk? Not a rhetorical question.
Hospital infection.
What's that?
Hospital infection.
That's bad. We don't like those. Not #1 though. Any other guesses? Race and ethnicity.
Obesity.
Obesity's bad.
Poverty.
Huh?
Poverty.
We're getting closer here. I usually get some smokers out there. That means it's not so good for you. It's homelessness. If you're homeless, it's really hard to coordinate your care. Where do we spend our money in the United States? I mentioned that we spend more than twice as much as almost any other industrialized nation on our health care. But look where we fall in our total service spending. We're right about the middle there. Here we are. So you can see our healthcare bar is about twice everybody else, but we're right kind of in the middle of the road where everything else is. The majority of these countries have single-payer systems. In the United States, we do not have a single-payer system. Every system is perfectly designed to give you the results that it yields. The Institute of Medicine in 2012 published a report on primary care and public health. What do we need? Over here you have isolation, then you acknowledge that each other exists, maybe you start cooperating, then maybe even collaborating, maybe even having a partnership. Our design in the United States is that health care is a business and public health is a job of the government. We don't have any price sensitivity. Why should I make sure that health happens in classes and we talk about reproductive health? Oh, God forbid, don't give a condom away in a high school, much less talk about sex and what your period is and when it hurts and what happens with that and what's the deal with sex and how do you get pregnant and what's the deal with exercise and what are you eating and what's glycemic index? We can just wait for them to get fat and obese and diabetic and then we can make money in the health system to take care of them. We don't invest in the public health. We have a system that is not linked to that, and so that sensitivity, I think, hurts us. Cambridge Health Alliance, we're one of 2 organizations nationally where we are the Department of Public Health. Cambridge Health Alliance, we are the Department of Public Health for the city of Cambridge. Denver Health is the other organization that has that model. But the idea that we are inextricably tied to our communities, and if we don't try to figure out how to engage our communities and try to raise that health together, then we're probably not going to do a great job. So we own 3 school-based health centers. Cambridge High School, Somerville High School, and Everett High School. We're in Malden is where our clinic is. We're there a couple of sessions a week and we're writing grants to try to build a school-based health center there. That's what we want to do. Our residents do community health assessments. They do community health curriculums. Each city that we're in as Cambridge Health Alliance, we have a manager of health improvement for those cities. Ours is Renee Cameron Hamilton. She's amazing. She has her master's of social work and her master's of public administration, and her job is to know the city, is to know our community, because that, again, is about relationship. Relationships take time from food. You have to invest in those and try to figure out your structure if you're going to build that relationship to be able to affect change in the community. Another thing that we're doing is a one-question project. When we're getting vitals, let's also ask somebody, are you interested in becoming pregnant or planning to become pregnant in the next year? To which you get one of 2 answers. No? Great. What are you doing for contraception? Yes. Great. Let's get you taking some folic acid and talk about what we're doing there. I really like people to be pregnant when they want to be pregnant. I still deliver babies. I love it. It's one of my favorite parts. But I think it's also really is tied to the cycle of poverty in a lot of ways. When people are having babies, that they're not ready to have babies yet. And they don't know that they want to, but how are they figuring out how to do that? We recently got a READY grant, which is the Reproductive Health Education and Family Medicine Project, which has an anonymous donor to fund primary care education in full reproductive health delivery, including abortion services. Most of the things that we do are not all that different. An aspiration abortion is not very different than an endometrial biopsy, which we do in our office every day. We've built in barriers for people to get this kind of care. We've built in barriers for people to, a lot of people didn't even know medication abortions exist. There's lots of things that we can do and care that we can deliver that right now we make it hard and stigmatized to get that care. The real answer, I think, is team-based care. I wrote down as Tim was talking, he used the word outsourcing a couple times. I need to outsource. I have way too many people that need my services. I saw patients this afternoon, and I'd say probably about a third of them didn't really need my big expensive brain. My nurse could have done it. Certainly my PA could have done it. How do we start getting the right amount of care when and where it's needed? I do believe strongly that relationships are very key to a strong healthcare system. That being said, for you young invincibles out there, if it burns when you pee, do you want to miss a half day of work, take the tea, sit in a waiting room for 2 hours, pee in a cup, maybe even have to be naked on the table for a while, just for somebody to give you an antibiotic to tell you have an uncomplicated urinary tract infection? No, we don't. We can safely treat that over the phone. We can ask you if you have fevers, nausea, vomiting, chills. Does it look like it's anything else? Anything else going on? If it gets worse, let me know so we can get you in. Maybe we do need to see it. But if not, let's just call in that antibiotic. In a fee-for-service model, there's no way for me to capture charges on that. So I need to develop a urine workflow and make sure that those people get into my office. If we start getting paid as an accountable care organization, and right now at Cambridge Health Alliance we're at about a 50-50, which is an interesting place to be because you have to kind of perform on both. All of a sudden we can start staffing very differently. We've hired a lot more MAs in the last 2 years with the idea that, you know what, it is ridiculous to have a physician that's paid $170,000 running around the clinic looking for somebody to assist them to do a pelvic exam. That is waste. How do we systematically identify it and eliminate it? We've hired a planned care coordinator whose sole job it is to look through our registries and help us try to figure out how do we outreach to that diabetic who the last hemoglobin A1C was 12, meaning it's really out of control. Where did they go? Did they move back to Haiti? Can we get them back in there? Why are they not taking their insulin? Let's get them here for a triple visit. What's a triple visit? They see me where I mostly don't do very much. My primary job there is to transfer my power as a physician and my relationship to introduce them to my nurse, who can sit there and spend an hour with them to do diabetes education, and then she'll do a warm handoff to our clinical pharmacist, who will titrate their insulin for me because I'm in clinic 2 sessions a week, and can call them daily or weekly to adjust their insulin until they're under much better control. How do we start to develop this team-based care? It's not just about doctors. It's not even just about nurses. The one with the really nice tattoo here, Robin, on the left, on the right, she looks a hell of a lot more like most of our patients than I do, than most of our nurses do. Physicians very oftentimes are transplants into the communities that we work. Transplants are suspect. I grew up in a small town in Kansas. My dad lived there 35 years and he's still newbie. It takes a long time to win that trust. How do you start to build these relationships? Now we're going to talk about throwing rocks and throwing birds. I'm talking about South Central Foundation, which is a health system up in Alaska. Don Berwick, again, my man crush, said that arguing that cost-effective, high-functioning, quality care is impossible in the current healthcare climate is like sitting below Logan and saying that flight is not possible. They're doing it. They're doing it across 150,000 square miles. It's Alaska. It's wicked big. What's their entire model? Their entire model is under the premise that we've really gotten it quite wrong in the healthcare system. So, on your y-axis, you have control. Who's in control? On the bottom, on the x-axis, you have acuity. Now, when the acuity is very high, when I'm walking out of here and I'm having a nice conversation with Tim about how well I thought the evening went, and I'm distracted and I get hit by the MBTA bus, I don't want anybody asking me how I feel. I want Tim to whip out his GPS-enabled cell phone that calls the nearest ambulance service, that pinpoints my exact location. An ACLS team is there in less than 5 minutes. They put in 2 large bore IVs. Hopefully they start some morphine, for God's sake. They call the trauma center that they're driving me to. They know my blood type. They're cross-matching and screened. The clinic is there. They're ready. The trauma surgeons know that I have broken something. They're ready to take me. They put me on there. They know what I'm allergic to. They give me antibiotics before they cut me to reduce the risk of surgical infection. They admit me to the ICU, and they change my intubation tube regularly to prevent ventilator-associated pneumonias. We don't do this very well. I'm not conscious. You can do whatever you want to me. Get the system to get it right every time. Every time. That's throwing rocks. We can do that. That's the target. This is what we need to do. We got to figure out how to hit that target every time. We can build some sweet catapults, maybe some pneumatic guns, so we can get it right. We got to get it right every time. My world is not in the ICU. I'm not a trauma surgeon. I'm a primary care doctor. I told you before, my stock and trade is relationship. So, if I act like I'm throwing a rock, where I'm actually throwing a bird, in front of your smartasses out there, live birds, and I'm trying to throw them to this target, which is optimized health, maybe I should ask the bird what's important to them. What are their goals about their health care? What do they think they're capable of doing, of helping them get to that target? Because maybe at best, I have 10% of control of launching them in some trajectory to try to get them to that target. I need to talk to that bird. I need to know that bird. You know what? Who's going to have an easier time getting to know that bird? Robin is. Yeah, Robin bird. I didn't even think of that. That's good, right? Because Robin's in clinic every day. For my salary, we can hire a lot of Robins. And you know what? When we get smart about scheduling, and Robin's routinely working with me, so every time that my patients come to see me, they see Robin, they get to know her. They have that relationship. So when Robin calls and says, hey, you're overdue for your mammogram, can I schedule that for you? It's Robin. I know Robin. I trust Robin. Because I called Robin last week and told her it burned when I pee, and she got a hold of Dr. Sawin immediately, and he sent antibiotics for me. That's great. How do we make this system work smarter and work better? So we're going to have more ATMs. We're going to have more docs in the box. We're going to have a lot of different ways to take care of patients. But not every patient has an uncomplicated UTI. Most of my patients are actually the hyperdiabetic obesogenics. Usually with a touch of mental illness shaking on top. So they don't come to appointments. So how do we take care of them? Non-compliance, we go get them. Exactly. We go get them. Because in our old model, in the fee-for-service model, I can't get paid unless they come to my office and it's a physician visit and it's a Department of Health certified location. Now that all of a sudden we're starting to get paid per member per month to take care of a population, you know what? There's a hospital-at-home nurse practitioner that sees every patient before they leave the hospital now. And they go do a home visit within a couple days because we don't get paid for readmissions anymore. So we can start to staff very differently. We can start to do our work very differently. The thing that scares me a little bit about the ATMs is those, whether it's the ATM or the Ready Clinics or the Walmarts, they need to be connected to the bigger system. We need to do that because right now we are not patient-centered. It's really hard to get an appointment, and you'd have to spend at least a half day to get my services. And that is just not patient-centered. It's not patient-friendly. How do we get better at that? But when we do realize, you know what? That's actually the 4th urinary tract infection that you've had in a year. That's not normal. We need to work you up to make sure that there's not some weird thing with your anatomy of why you're getting recurrent infections. There's something else actually going on. If we have just those urgent clinics that aren't able to catch those patterns and see those bigger pictures, then we're also liable to lose some people in the gaps there. That's how I'm going to save the U.S. healthcare system.